It's always just a little bit different on Teams, isn't it? It's a very slow minute, Georgia. 2 minutes now. There we go. 2 minutes. On to affirm us. Someone else has just arrived on the 2-minute mark. Brilliant. So welcome everybody. Thank you for joining us today. Just so everybody know, this meeting will be being recorded. That recording will be held on the Training Hub at the moment. Due to changes in the Training Hub, the recordings for the cancer meetings are going to be moved to another platform. We haven't quite figured that out yet, but we will do, and we will be letting everybody know as and when that happens. As the meeting is being recorded, and people are very welcome to have their cameras on. I'm very happy for people to do that, but just be mindful if you do have your camera on that you are potentially therefore being recorded, and you may not want to be moving around the building or eating your sandwiches on camera. If you're happy to, you're very welcome to, but just letting people know. And obviously please keep yourself on mute unless you want to ask a question, in which case you're very welcome to come off mute to do so, and there'll be plenty of time throughout the course of the next hour to ask any questions if you have any. So Roger, have you started recording now? Are you happy to go ahead and click record? It hasn't popped up for me to say yes or no. Yeah, that's brilliant. Thank you. So I will go on to the next slide. So hopefully everyone is in the right meeting. So the focus of this meeting today is on FIT, so fecal immunochemical testing, which is a test to look for blood in the poo, or stool as we like to say. So I'm Glenda, I'm a GP at White Ladies Medical Group, and I'm also the cancer clinical lead at our ICB, and I'm joined by Georgia Diebel, who can introduce herself, in fact.
Hello everyone, I'm Georgia and I'm the primary care facilitator for cancer early diagnosis. So thank you for joining us.
Thank you. So why are we here today? So we're here today actually because we had feedback from primary care colleagues that it would be helpful to run this session again. We have run this session previously, and that feedback came from a FIT task and finish group we ran through sort of late 2024, and we had representation from every PCN across BNSSG with a real focus on improving successful completion of FIT, as well as looking at safety netting practice and how we can address health inequalities related to this test. And we will be chatting through that today, but the background to what is a FIT. So it's an immunochemical test. So it's a test that is run at the lab at MBT, and it's a surrogate marker for bowel cancer. So having a positive test doesn't mean you have bowel cancer, but it absolutely shifts the probability that you do. And it's looking for blood, and it's blood that could be coming from a cancer within the bowel that's bleeding, or from polyps. So polyps are little pre-cancerous conditions. So they're like skin polyps inside the bowel. If you have skin polyps, please don't panic. Skin polyps are not precancerous, but if you get little polyps within the bowel, then they are precancerous and they would be removed and they can bleed. So this FIT test is looking for that bit of blood in the poo and trying to pick that up and saying, actually, if you have got blood in your poo, it shouldn't be there, and we need to try and understand why that is. So we send those samples off to the lab at North Bristol, and they analyse them. There's some whizzy machines, and then they will give us a result, and that result has a numerical value, so we know exactly how much blood was in that little sample of poo that was taken, and then we can use that within primary care to guide what do we do next. Can we actually, on the basis of those symptoms and examination, can we reassure somebody, or do they need further tests to look for bowel cancer, for example? So it would be good if people could put in the chat, like, have you seen this before? You can thumbs up or not. But a while ago, George and I developed this poster which was circulated around primary care because there is so much confusion around this test. There is confusion both with the test being used in the National Bowel Cancer Screening Programme, but also used for patients we see in primary care who have symptoms that could be bowel cancer. And we're aware that often people are falsely, sadly reassured because they think, oh, my bowels just haven't been quite right, but it's okay because I had that kit come through the post and that was negative. So therefore I can't have bowel cancer because the Bowel Cancer Screening Programme told me my kit was negative. There is information that comes out with that saying if you have symptoms, please don't ignore them, please get them checked. But we know that not everybody reads every line and every information we give to them. And the reason that there is that challenge with that is because the FIT that comes in the Bowel Cancer Screening Programme has a different threshold for a positive test. So you can see on this poster the sort of line above the blue band at the bottom. So to have a positive result from a screening programme test, you had to have over 120 micrograms of blood per gram of poo. Whereas for patients that we see in primary care who have symptoms, it's totally different. So a positive test is over 10 micrograms per gram of poo. So really, really different thresholds. That's why those patients need to be managed really differently. You can also see on this poster we've got the two sort of pictures of the different stool kits we collect in primary care, showing which one should be done for these fit tests, as opposed to if we think someone could have giardia because they've been on some exciting trip abroad and the bowels haven't been quite right. So this poster was sent out to primary care, the idea being that it was to be put next to where the fit kits are stored in our treatment room, so everybody's sort of familiar with that. So it'd be really good to know if anybody has seen it in primary care, if you could put a thumbs up. Otherwise, no fear, because we will happily distribute it again. And it just outlines those things. There's something I do want to flag from it, and that is that within BNSSG, we are currently trialling a lower threshold for a positive fit result from a screening programme. So that's dropped to 80 rather than 120. I've got a bit of an echo, so I don't know if someone's not on mute. We dropped to 80 from 120. What does that mean? That means that we will hopefully pick up more polyps, more early cancers, and be able to diagnose people at an earlier point. It doesn't mean people can then be reassured if they've got symptoms, because it's still, eightfold difference at 10 to 80, but should hopefully improve our early diagnosis of bowel cancer. So I'm going to, at that point, hand over to Georgia, who's going to talk a bit more through the Bowel Cancer Screening Programme and how that works, because our patients are receiving these kits and lots of them are unfortunately not returning them. So we really want to support them to do so, because this bowel cancer screening can make a massive difference to patient outcomes. Thank you, Georgia.
Thanks, Glenda. Can you hear me? I'm just adjusting things a little bit with our sound system. So it's good to see some thumbs up in the chat there to people having seen Potting the Poo posters, but hopefully through this session we're going to build your understanding a little bit more about the difference of the two pathways. So I'm going to talk to you about bowel cancer screening specifically. So that's the one that it has the higher threshold. Next slide, please, Glenda. So the first thing to say about this is obviously we're wanting you to understand it from your practice's perspective, but also at a personal level for all of us and all of you. There's either yourself if you're over 50 or your family or friends and all your patients who are eligible for this test. And it is a game-changing test in terms of finding cancer, well, precancerous changes that can prevent people from getting bowel cancer. So if what you take away from today is an understanding about this age change, that's a fundamental thing to know about. It used to be for people who were aged 60 to 74, but in the last few years there's been an age reduction scheme in place, and as of August last year, BNSSG patients are now sent a kit from the age of 50. Now, if you had already turned 50 last May, say, you won't get a kit until you're 52, because it's every even year. So from 50, 52, 54, 56, etc. So if somebody was 52 last year, they won't get a kit until they're 54. So it's sequentially every 2 years. But it's everybody now going forwards from the age of 50. So we have had a few queries coming in from people saying, well, I'm 51 and I haven't had a kit. You get the kit when you're 52. So next slide, please, Glenda. So the Bowel Cancer Screening Programme is a national screening programme. So it isn't managed by us locally. It's run by the Bowel Screening Programme Hub in Surrey, and they're responsible for the whole of the south of England population screening. So this is for people without symptoms. So it's everybody. Everybody is eligible from the age of 50 to 74 that's registered with the GP. So the list is pulled from your GP practice list. If people are homeless and they have no fixed abode, they won't get a kit without being registered through a practice in some way or other. The kit arrives in the post every 2 years from the hub, and it's got a barcode on it that makes it unique to that patient. So one of the important things to remember is that you can't give a kit from practice to somebody who's asking you about bowel screening. Their invitation letter arrives telling them about the bowel screening, and then 7 days later they get the actual kit. So there's a pre-letter telling them it's coming, then the kit arrives. It comes in a box, it's pre-labelled, there are instructions for use, and there's a free post envelope to return it. And then they should return it as soon as possible, and they will get a results letter within generally a week to 2 weeks. So the hub sends the result to the patient, and if it's a negative result, then that comes through to the practice electronically and is just recorded. But if after the set period of time they don't respond, then the non-responder notification goes to the practice, and that would be when we would hope practice teams would begin to support the patient to think more about getting the bowel screening done. If it's a positive test, the patient is contacted directly by the local bowel screening programme team who are based at the BRI as part of UHBW. And the next step for the patient then would be probably an investigation like a colonoscopy if the patient agreed to have that done. Next slide, please, Glenda. So we wanted to show you what the kits look like. If you think back to the COVID testing kits that arrived in a box in the post, it's very similar. It's a cardboard box. Everything is recyclable in the box. There's a plastic tray with the little stick kit sitting inside it and an instruction sheet for people to follow. And the free post envelope has a self-seal, so nobody has to lick the label or anything. They just put it straight back into the envelope and post it back. Next slide, please. So with the initial invitation letter, if English isn't the first language, on the reverse of that letter, there's information in the languages you can see on the left there that advises people to call the free phone number, and they will be sent information in the correct language. So that contact telephone number there is for the hub in Surrey, and there's a team of people there that deal with all the queries, or if somebody's mislaid their kit, they arrange for one to be reissued because it has to have that barcode on that's specific to that individual. There are also a series of videos in various languages, and we are sharing these slides with you with the links, so you'll be able to use those videos if you're creating an Accurix message in a certain language. Those can be attached to the Accurix that you're sending out. Next slide, please. So what happens if the kit isn't returned within the 28 days? So the hub allows a period of time for the person to receive the kit, to think about it, to actually then use the kit. If they haven't responded, they automatically get a reminder letter sent by the hub. If after 13 weeks there's no response at all, then the episode is closed by the hub and they're invited again 2 years later. But in that interim, the hope is that the prompt from the practice for those non-responders will generate the patients to actually get on and do the test. If they've thrown it away or they've mislaid it, they can call that number to get a replacement kit. If you think that a patient needs more support, or you want to request the kit on a patient's behalf, or if they don't have a postal address, if you go to that link on Remedy at the bottom there, there's guidance on how to request a kit on a patient's behalf. Next slide, please. So normally we have a colleague alongside us, Lynn Sandals, who's the learning disability screening practitioner. Unfortunately, Lynn couldn't be with us today. So I'm just sharing 3 slides on her behalf. And this first one is around correct coding for people with learning disabilities. So Lynn was explaining to me that from a coding perspective for learning disabilities, it's a national problem. It's not specific to BNSSG, but we aren't coding sufficiently in order that the lab in Surrey can pick up on people needing easy read information and reasonable adjustments. So from a coding point of view, learning disabilities sits at about 0.5% as a coding in your systems, and it's believed that LD representation should be at about 2%. So there's guidance for general practice for GPs in this top link about how to identify people with a learning disability and to then code them appropriately. So if you could share that with your colleagues around identification of people with a learning disability. This coding is so important because from a screening perspective, they can send out better information that's more appropriate for people if they know. So there's been a recent adjustment to the system that now pulls through that LD code, but if they're not coded in the first place, then that's not feasible. Next slide, please. So Lynn also wanted me to convey some of the challenges that people with learning disabilities have around the notion of doing their bowel screening. And how they might interpret the general information that's sent out. So this first chap that she has shared with us here, he was a man with autism who didn't know how to get the poo sample. He didn't understand that he needed to collect the sample in a plastic tray, sort of a bit like a grape or a strawberry tray that you put into the loo. And he thought he had to poo on the floor, and he couldn't do that, didn't want to do that. And so Lynn's role in part is to help people understand how to do the samples. And so she demonstrated using a Play-Doh sample and showed him an accessible video. And then he went on successfully to complete his kit with that additional support. And then she had another person who was concerned about the idea that he was sending his DNA through the post, and he thought that it was a scam. So an explanation of what the test is and using easy read resources resolved that for him, and he went on to do the test as well. Then I think not exclusive to people with learning disabilities, there's the issue of dexterity around using the small sample pot. And in this case, the carer declined to support the sample collection. So Lynn was able to speak to the manager of the care provider and made a plan for someone else to support the patient so that the sample was collected. And then the final one that she's shared here is that the carer is unable to get the poo sample from the resident and thought that it was appropriate to ask for the person to be removed from the bowel screening programme. And Lynn's concern here is particularly that people with learning disabilities have a higher incidence of bowel cancer. So their bowel cancer screening is equally, if not more important than the rest of the population because they are at higher risk. And so Lynn intervened and discussed with the carers and found a way to support the patient to get the sample done. So Lynn has a very specific skill set and guidance that she can lend to any of your situations around bowel screening with your learning disability patients. So she's really keen that you get in touch if you've got issues with an individual patient or if you want guidance on improving bowel screening for non-responders who've got learning disabilities. So the final slide here is the resources that are on Remedy around learning disabilities and cancer screening. They're there within the system, so please have a look and utilise them. And then lastly, just to say that Lynn's details are on the next slide, along with my colleague Vicky, who is on the call today. I'm retiring next month and Vicky is in post now and will be from a general screening perspective. Vicky will be your port of call, and then from a learning disability screening perspective, your point of contact will be Lynn. So hopefully that's clarified things for you around bowel screening, and I'm going to hand back to Glenda, who's going to take you through symptomatic fit.
You have one last slide, George, but I will talk to it. The key messages, key messages, and this is not unique to bowel cancer screening. In fact, same for cervical cancer screening as well. That it can detect cancer early when it's much more treatable and curable. So people, we know if we diagnose cancer at a much earlier stage, the treatment is less aggressive and much more likely to be successful. But really key is it can prevent bowel cancer from developing. So those polyps that we know go through that sort of adenoma, carcinoma cycle of change, if we can identify those polyps and remove them before they become bowel cancer, then that is a very straightforward procedure, and much better to never have cancer. So really, really key messages for patients. Sometimes people can be a bit fatalistic about things and think, oh, well, if I get cancer, I'll get cancer. It's like, actually, this can stop that happening. let's really try and keep that message out there. So fit testing in primary care. So as Georgia has highlighted, the screening programme is managed from Surrey. So the samples come out, the kits come out through the post, patients get them at home, they complete them at home, they send them back to Surrey. That all gets managed through them until people get a positive result, in which case they will come into local sort of next steps. But we use FIT in primary care a lot, and that is for patients with symptoms, not screening. So this is a lovely little Bowel Cancer UK infographic, just highlighting those symptoms. So again, Georgia and I always say with the education we deliver, we're really keen to support anyone who attends our education to understand their own personal risk. If people, people listening to this now have got these symptoms, please make a GP appointment. Or you've got family friends, it's to be really symptom aware is a really key thing. Our population can be very stoical and present quite late with things that actually we could have managed very differently if we'd seen people at an earlier point. So lots of work is happening to try to raise awareness of symptoms. You may see it when you open packs of toilet roll now. There's a little sign on there saying, if you've got any of these symptoms, please make a GP appointment. So really flagging that to everybody. So when we request a FIT for a patient with symptoms in primary care, as we've flagged, that we have to use the special kit. Okay, so we request that test on ice as we do for all of our other results, that we print off the form, we label it up to give it to patients, and we must give them the correct kit. So this is off that potting the poo, getting the right fit poster. So the correct kit is the one that comes in the special envelope, labelled up as fit kit. It's not that blue lidded pot. If we send samples in the blue lidded pot, the lab can't process them. So the fit kit has got a special buffer in it, so it keeps the sample stable. If you take a sample at a later point from that, then the blood may have degraded and not be picked up. So it has to be taken from a lovely fresh poo and then it is stable in that kit for a few days. But like I say, the other kit isn't great for that. So these are the envelopes that should be familiar with everybody. Highlighting to us as clinicians, it says doctor. I'm aware lots of clinicians are working across primary care, not just doctors, saying please complete the ice request before we give it to the patient to make sure that it gets labelled and sent back appropriately, and flagging to the patients that there must be the barcode label in the envelope sent to the labs to reduce the risks of samples not being labelled correctly. Within the pack, you can see the various things with a really clear instruction leaflet. And I often will talk patients through this and sort of flag how to collect their sample, how to use the kit. Key things about this, and these are really key things, and you can see I've underlined point 3 there, is the safety netting. So historically, if I saw somebody who had symptoms where I was concerned about bowel cancer, I may be referring them straight on an urgent suspected cancer pathway to the hospital for a colonoscopy or another diagnostic test. These FIT kits are really great because it means for some patients they won't actually need to have a colonoscopy, and if any of you have had one, it is not the most joyful thing to have done. Really important if you need it, but you don't want to have it if you don't need it. So by using these FIT tests, we can say to some people, actually, do you know what, on the basis of this being negative, I can be really reassured that your symptoms aren't something more concerning. Let's try this first, or let's follow this different route. Let's just give you a little bit more time to see if it settles. Please come back and see me. But the challenge, of course, now is that some of those patients where actually they do have a bowel cancer, we're adding an additional step before we can refer them on. So I'm seeing them and I'm counselling them and I'm saying, I need you to do this kit. And I will always say to people, it's really important you do this test. This test will help me know how to manage your symptoms. You've told me about your symptoms because you were worried about them. Just seeing me and talking about them is not going to necessarily get to the bottom of that. We need to do this kit. So please, can you complete this by the end of this week? Drop it back in and we'll get it off to the lab and we'll get the result back to you next week. But we know that doesn't always happen, that people are busy, may have switched off at some point in my conversation. They may have thought, Glenda is going on and on, I'm not very interested in this. So people may not have heard the information that I think I'm trying to impart really clearly, and therefore they don't prioritise it and they don't get this done quickly. So safety netting is so important. I was talking to a GP colleague this morning who said they'd just done a review of their non-return fits. And sadly, someone in their mid-30s hadn't returned their fit. There was a delay of 3 to 4 months and they prompted them, and actually they've turned out to have bowel cancer. So we have added a bit of a risk to the pathway here, and we need to share that risk with patients, make sure that they are counselled appropriately, and then support them to get that test done. So some patients may struggle with completing the test, and I guess again it's flagged an individual with a learning disability, talking to their carers, saying actually they're going to need support to do this. There's some things in terms of completing the kit itself that can be hard to understand, which I'll talk people through. There is some research around this, and one of the things we said at the beginning was around the role of health inequalities and this pathway, and we know that adding this test in has that risk of increasing health inequalities. So this is an interesting study done about the uptake of FIT in primary care. So it's saying actually people have been advised to do a FIT. Has everybody returned at the same rate? And we know that everybody didn't return at the same rate. That actually men were less likely, having been advised by their clinician that they needed to do a FIT, they were less likely to bring it back. Younger people, well, and maybe they thought, I'm not really at risk of bowel cancer, it's probably not going to happen to me. So younger patients were less likely to return a FIT, whereas someone who was older, who was more concerned that there was something sinister going on, were more likely to return it. We know deprivation really impacts on this. So our most deprived patients were less likely to return their fits than the is that correct? I'm going to more than double than most compared to the least deprived. Yeah, so our most deprived patients were less likely to return their fit, as well as we know that people from global majority health groups, again, are less likely to return their fit kits. So that counselling at the beginning is so important, helping patients to understand that we are doing this because we are worried there's something more serious going on, and recognising where people may need additional support to do that. But then having our safety netting processes in practice. So if someone hasn't returned their kit, we pick up on that and we prompt them and we support them. And there is this wrestling thing about sort of not being paternalistic, about shared decision making, about people not engaging, but ultimately these people may have bowel cancer, they have got symptoms, and we need to get this test to know what to do next with them. So I really encourage practices to really make sure those safety netting processes are really robust. And we feed into that return rate with knowing that actually, so men are less likely to return their fit, but they're also more bowel cancer is more common in men. People who are living in areas of greater deprivation are more likely to get bowel cancer, but they are less likely to return their fit. So we're compounding potentially that health inequality. And we know that once someone has a diagnosis of bowel cancer, actually their outcomes are different depending on sex, ethnicity, and socioeconomic variability. So we really need to be recognising these patients early and getting them treated quickly. The same thing is seen within the screening programme. So that first data I presented was around symptomatic fit, but actually if we look at the patients who take up that offer of screening, again, it's lots of interplay with that in terms of ethnicity, socioeconomic deprivation. So we know that if we look at bowel cancer screening uptake within our practices, we'll see that there are certain groups that do that less and maybe need more support, need more assurance that this is the right thing for them to do. Sometimes patients complete the kit and the lab can't process it. And so that adds in delay to that patient's journey. And you can see at the bottom of the slide the reasons for non-completion. And the main one, so this is in the last year, we've had over 300 kits sent in that blue lidded pot, so in the incorrect container. So, that patient has been given the incorrect container, they've gone away, they've done a poo sample. It's not the most fun to do a poo sample, but they've done it. They've dropped it back off, we've sent it off, and the lab has gone, sorry, can't process it, incorrect kit. So they let us know, we then contact the patient, they have to get another kit, they have to do it again, they have to send it off. And this all takes time. So there is that challenge in terms of delay on that patient's pathway, but also just time for us as busy healthcare professionals, busy practices, managing these patients, letting them know, them queuing, coming up into reception. So giving them the correct kit the first time is so important. The next thing around this was around samples leaking. So the little kit is a little bit tricky. We mentioned earlier around sort of dexterity and being able to do that. Some people with sort of arthritis in the hands may struggle a bit. People with learning disabilities may struggle a bit. But samples leaking is an issue. So I always say to patients, make sure when you've taken your sample, you twist the lid and it should click. When it clicks, you know it is shut. And if we could really make sure that message is getting through to patients, it is in the patient information leaflet. But as we flagged earlier, people don't always, not always able to sort of follow that information. So just affirming that is really important. This is a delightful sample. I'm sorry if anyone is eating their lunch during this meeting. But this is one of the samples that the lab received where the patient hadn't quite followed, maybe didn't feel comfortable, but essentially they sent their whole poo in a bag with the kind of collection stick just to the side of it. So they didn't want to do that bit. So here's a poo and the lab can manage that. And as I said earlier, the lab can't unfortunately process that sample because blood is not stable in poo. And so therefore it had to be rejected and then asked for the patient to do that again. You can see they're wearing really good thick gloves when they're unpacking and managing these samples. So sample collection kits, really important for patients to use the correct container. Everyone needs to know that the lid must click to close. Some practices have asked us in the past, if patients were struggling with that, could they do a sort of a stool sample in a normal pot and bring it into the practice? Then the practice take the sample from that, and unfortunately we can't because, as I said, it's not sort of stable blood in the poo, so it has to be fresh stool taken directly into the fit picker. Once it's in there, it's stable for 14 days. If someone says, well, I can do it, but I can't, I only have someone come and visit me twice a week, and so I can't get out to the post office, that's fine. Try and do it obviously the day they come, but it is stable for that bit longer once it's in the fit picker, so it doesn't degrade in the same way. So this is a very cheery photo of the team at the lab with their machines, and they provide the sort of symptomatic fit testing for our region. So they're receiving samples from Gloucester and Somerset and BSW, so Bath out Salisbury way as well. There are lots of resources out there for symptomatic fit. So Accurix have got a pathway. So if we're giving out these kits to patients, then we can send this pathway which sends out prompts to patients. So if patient has done it, then that's great, but it says, have you remembered to return your fit? If you haven't, please do it as soon as possible. So it's a way to get that, and that's obviously really straightforward for us to send from primary care. Within Ardens, there's obviously also tools to use, and I know lots of practices have developed safety netting processes where if we haven't received a fit result within an agreed period of time, that those patients are then contacted to say you've not sent this back, and if they still don't send it back, then there's a discussion with the clinician that requested it. So this is, again, just that key message to really reinforce is around that different threshold for patients with a screening test and a symptomatic test. Screening is population level, patients without symptoms, very different threshold, acknowledging it's coming down, but still very different to those patients we see who are symptomatic, where we have that threshold of 10. So there is a good video you can play in your waiting rooms about sort of bowel cancer symptoms and spotting the warning signs. Like I said, that's embedded into the slide deck that we will be sending out. And there is so much other learning out there. Gateway C are a great organisation providing lots of learning around cancer, and they've got specific learning around the screening programme, so alongside around FIT, and it's run in primary care, lower GI pathways. So lots of great resources out there if people are interested and want to learn more. And Georgia and I, and Vicky, in fact, who's taking it from Georgia when she retires at the end of March, would be really happy to receive any questions that people have on this or any support practices want. If you think actually maybe our safety netting isn't as great as it could be, we've got loads of great examples from other practices and PCNs around the area that we can share, who have agreed for us to do that, to support practices to make sure that all works out okay. And that's the end of the slide. So I'm going to stop sharing now, come back into the room where I can see anyone. So I don't know, Georgia, if there are any questions.
I haven't seen anything in the chat, Glenda. Okay.
We have whizzed through that today.
We
Georgia.
have whizzed
Sorry
through
if I spoke
it.
too quickly. I have a tendency to speak too quickly. It's the GP element of me. So I try to not be too quick.
We've got a chance now for questions. If anyone wants to come on and ask anything, or raise your hand or put anything into the chat. We don't want to keep people unnecessarily, but we hope this has been helpful. I think, Roger, you're going to put the feedback form link into the chat if you're there.
Yep, just going in now.
Thank you. It would help us to know whether this session has met your needs in terms of understanding the difference between the two fits and the pathways that they use, and has helped to clarify things. So anything that you can put into the feedback form would be useful to us, just to make sure that next time we deliver it, it's fit for purpose.
Oh,
Excuse the
Georgia.
pun, I couldn't resist it. But I can't see any hands going up or any questions. Is there anything else, Glenda, that you want to reflect on? Oh, we've got a round of applause from Roger.
I love you, Roger.
Thank you, Roger.
So no, so I think, like I say, feedback is really helpful. You know, we're trying to support everyone across primary care to understand the importance of this test, the importance of it for us, family, friends, and for our patients. And if there are other resources or other things we could be doing to support that, that would be really helpful. Sadly, bowel cancer, is one of the kind of leading cause of death. We know that rates are increasing, and particularly increasing in younger adults. And this FIT kit is really helpful for us picking up people at a younger age, because it is a sort of non-invasive, straightforward to do test. And yeah, having had 2 friends die of bowel cancer, who's pre the introduction of FIT testing, their outcomes may have been different if we'd been able to offer them this test then.
So just to put that in context, bowel cancer is the 4th, well, they're now saying it's the 3rd most common cancer. It's gone up the league, and it's the 2nd biggest cause of death, and it is beginning to occur much more in younger people. So this test couldn't have come along at a more important time in the evolution of tests. So it was introduced to screening just before the pandemic, and the pandemic accelerated the use of it in primary care, I think it's fair to say, and it is a really valuable test. So we can stop there. Roger, I don't know if you've managed to get the link into the chat.
It is in the chat.
Yeah, okay.
So if everyone, so Roger, if you're happy to stop recording, so no questions. We are, please, if people take a minute to complete the feedback form and then log out and enjoy your next 22 minutes of
it's always
break.
good to have